decide whether or not to
Recording in
initiate
progress.
therapy. And if we can't appropriately risk stratify with just one FAF, I wonder if we become a little bit like glaucoma doctors who say you need 5 visual fields to decide a baseline and decide how to assess glaucoma. Maybe we need more FAFs over time to really decide a baseline. But on the other hand, we know that treatment of GA early tends to have better results than waiting until sort of the ball runs downhill. But those are my thoughts on this article.
Well, I think you picked up a whole bunch of good questions. I'll ask you, Kat. How often are you, when you're sitting there looking at your GA patient, looking at your perilesional autofluorescent pattern and stratifying it based on the different morphology and telling the patient that that's why you're going to initiate, or that's why you're going to see them back, or factor into their risk discussion?
Yeah, I think that's a really good point. Normally for me, I mean, I think autofluorescent imaging is really helpful, especially for patients who you don't have any imaging on before. I would have to say that for patients who have already been seen in my system, I actually rely more on the infrared images of like an OCT to be able to get a sense of how fast someone's atrophy is growing. I just find that like much easier, and I'm much more likely, sort of in our system where I'm part of a large academic institution, we the optoms and comprehensive people in our group, like I could often track imaging to be able to get a sense of if things have grown or not. But if I haven't seen anyone before, and certainly if I'm having like a formal discussion with a patient about starting complement inhibitors, I'll get baseline autofluorescent imaging. And it's most helpful for me if there's, hyperautofluorescence at the edge and like a sort of, the people who are more likely to treat like extrafoveal multifocal lesions. I think what was interesting for me sort of about this article is, sometimes I'll see people who have been referred to me by optometrists or comprehensive people for an opinion on if they should sort of start treatment. And so I'll get imaging at that visit. But if I don't think that they're very high risk, or, have a discussion with the patient, they're not interested, then I'll often say I don't necessarily need to see them again, especially if it feels cumbersome to the patient to see me again. And then they'll just have that sort of one image. So I think mentally in my mind, I've always sort of put people in different autofluorescent sort of categories, rather than thinking about them changing. I think the reassuring thing about this article is if the people do change, like you put them in one sort of camp and then you don't get imaging again. If it doesn't change, they don't seem to progress as much. But it is something sort of interesting. I think about atrophy growing on autofluorescent imaging, but not really switching patterns, if that makes sense.
Now, Jay, I'll ask you, when we're talking about switching patterns and stuff, are we really talking about stages, or are we talking about phenotypes, or what are we really doing with that? Is this, I know that we're talking about the importance of the pattern switch, but is that truly like a certain, risk factor, or is it really just we're watching the disease evolve?
This is where I know like everyone likes to throw out AI for everything these days, but I do think that AI would be helpful here, because I think we're a little limited by our abilities, to your point, of assessing a phenotype. We say, okay, we see this pattern. We've been doing it for years in retina. And as we've gotten better at FAF images, that's what we're doing for this condition. And there's obviously more interest in it now because we have options for these patients, right? So I'm with you, where I'm not exactly sure that these are disease stages, because how do you stage something? It's like you're trying to interpret something, you don't quite speak the language. And we don't really have great longitudinal data for years and years and years and years in FAF, in thousands of patients, right? I mean, that's one of the things. This is still a relatively small study. And so 22%, you might quote that switch rate, but did that apply to a population of 5,000 patients in New York? Is that the same for 5,000 patients in LA? Probably not. So I really think if we get big databases where AI can look at this, I'm sure it's going to come up with better patterns than we can do with the naked eye on our own. And I think the other kind of issue is, again, they talk about this in limitation section, is they started with foveal sparing GA, but what does that mean for later? So obviously these patients are quote unquote a less aggressive stage than patients who present later, but are we just picking out phenotypes of a stage? For example, we have other diseases that we stage like moderate NPDR. Moderate NPDR can look totally different between patients. You can be like, well, there's a pattern where there's exudates in the macula, and here's a pattern where, yeah, they meet criteria because they have venous beating, and this is a pattern where they have two quadrants of MAs. But like, that's helpful to say they're all moderate NPDR and those patients are all different. But are they really different, right? Are they ultimately, when you look at the big picture and take a zoom out and say, okay, what is their risk of progression to ultimately vision-threatening complications? Well, they concluded years ago, well, we lumped them all together because it seems like that percentage is the same for this group of patients. Now, that may not be true when you run those patients through AI either, but we don't even have that for FEA and GA at this point. So that's why I think there's a lot of this is one of the studies that I think is interesting because it raises questions. I'll also throw this out not as a grenade, but I think it's just interesting. They declared they didn't use GPT, and I think that's nothing to do with the purpose of the paper, but it's like an interesting subset discussion we could have in the chat or whatever. Is I think this is becoming more commonplace. Usually articles say they don't use it, and this is one of the articles like, no, we did use it actually, and we used it to improve. And I wonder if that's just going to become standard because I thought it was a little interesting thrown in there as a note, and most journals are requiring that at this point.
Well, I love. I'll dodge your grenade for a minute there to get beyond the ethics of the GPT, not ethics, or the commonality of it. I'll add to the AI component. I think you're looking about sort of scale, volume, and this whole lumping, splitting. How do we really lump people? Do we split them? We need some degree of lumping people together categorically when we're doing these kinds of studies to derive some sort of meaning. But ultimately, we net say there's a lot of splitting of the fine details of those. But what about the actual interpretation and the reliability of the interpretation of these different imaging features? I like that's always I kind of always my question I come up with where I feel fairly consistent about how I call it. It's probably not exactly the same as how Kat might call it, and I feel like that's another realm perhaps for AI's standardization of the imaging interpretation for these criteria. I don't know, Kat, when you were talking about like your interpretation, is that just sort of your gestalt when you look at the imaging, or is that validated with anybody else or with trainees that at least they keep you honest? That's sometimes how I feel my imaging interpretation gets standardized, but
Definitely. I mean, I think it is a certain like gestalt that you have to use. I think the area of GA is, I think, so interesting because I feel more acutely than like most other sort of bread and butter diseases that we take care in retina that like I'm still developing like my rubric for how to take care of these patients, right?
Mhm.
Like I think about like diabetic retinopathy or sort of my wet AMD patients and like treatment extending and that sort of stuff. Like I just have like rubrics in my mind. And then for GA, like you go to conferences and you read papers and you learn a lot, it feels like, about, different imaging patterns and growth rates. And you like know the canonical studies, but then you like see a patient in clinic and you're just like, how do I put all this together? Like, what is the growth rate here? And then, your fellow will ask a question like, you actually have this patient coded as like intermediate AMD, but don't you think they have GA polyphobia? That keeps you honest. And so I think it's hard when I'm like reviewing these papers, I always look for the images too that they, present, and not to suggest that the authors are misrepresenting imaging, but like, whenever any imaging paper is published, there's only like one example of each. And so I
Right.
look at them to get a sense of how would this compare to like what I would call them. And I think they're pretty accurate here, but you just like wonder where like all the patients are. And then you wonder yourself, like, your fellows do keep you honest, but I don't know. I'm sure your fellows are great. Our fellows are great, but I think my fellows are pretty honest with me about like, how do you treat GA? Like what's your rubric? And like, if you have patients on treatment for a while, like, how do you assess the imaging over time? And I just think as a field, for those practical pearls, I don't know if we've all, I don't know if everyone's come to a consensus on how we're going to manage these
So,
patients.
so could I ask a follow-up question? I'm curious what you guys think. So, what percentage of your GA treatment is based on your exam and imaging, and what percentage is based on your psychology and the patient? And I'll phrase that a different way. So, like, we have some conditions in our field, like a retinal detachment that's macula involving or macula threatening, let's say, that's rhegmatogenous. Like, it's not 100% based on your exam and your decision making, but it's like 99%. You have to involve the patient, consent them, but like you're basically telling them what to do, right? And then you could have something like, lattice, where you don't feel that strongly an asymptomatic person with a PVD. And then it becomes sometimes a question depending on how strongly you feel about do you laser or not. I'm not trying to go down that path. But my point is like there's a spectrum of how much it is the conversation, what are your needs, what's the patient versus, okay, I have this objective finding and I know what it is. I'm going to make a decision. With my point being, like, I find GA on my hands, I feel like, yes, it is dependent. Obviously, do they have GA? Is it foveal sparing? What's the history of the fellow eye? Like, there's stuff that's objective there. And we're going to get to the calculator stuff later. But I
yeah.
think a lot of it is still like that relationship and like, what is their psychological relationship with this disease? And what is their history with the disease, both personally in their eye or their family members' eyes, if they have parents?
Mhm.
But I'm curious
Yeah.
if you guys, I don't know if you guys feel the same way, but I feel like the imaging helps a lot, but it's not as definitive as other things.
Yeah,
No,
we're getting into this in like the imaging of our papers, right? Where I think like we'll talk a little bit more about management with the calculator and stuff too. And like I almost feel like there are certain parts of it that there's some almost like an ante, like there's some baseline findings that are objective ante to then enter into the discussion of these things. And then the rest of it is all that discussion. Like if I start discussing this and watching their reaction about how they bite on it and how they receive it, to your point, you mentioned lattice, right? I feel similar sometimes when we have that like laser for different various forms of lattice, high risk, low risk, whatever you might be, and you can almost see the physical cringe sometimes when you talk about the intervention, and you're
Right.
like,
Right.
"Am I going to do? I'm not going to do this." Are
Yeah.
you
You
kidding me?
backpedal. You backpedal
Right?
quickly. Yeah.
And,
Yeah.
and
Yeah.
so like
Yeah.
there's some like sort of feelers that happen in that discussion, and that's I think you're totally right that for something that is so commonplace in our clinics to have that degree of feeling out the person and that's very atypical for a lot of the very objective and very just data driven
mhm.
components of our field that we're able to just practice based on data to a large extent. And I think that's some of the aims of a paper like this. But I think there's a lot else that's more complicated. I don't know if Kat, if you have some other reflection.
Yeah, no, I totally agree. I think this is one end of the spectrum in terms of the patients we treat, and I think patient interest and motivation is by far the most important factor. Like for me to be able to sort of have the discussion, I already kind of in my mind need to take a look at their imaging and their history, and I usually do that before I'm going into a room with one of these patients. And I think in my mind, like, is this a reasonable person to do it on? But here, the patient needs to like 100% almost like convince me, like I'll lay it out, but if they're interested, then we'll continue. But then if I'm getting the vibes that they're not, then I kind of let it be. It's interesting, like wet AMD is like one end of the spectrum where I feel very confident kind of convincing people of for the need for treatment. DME maybe somewhere in the middle, and then GA is like over here, because I think, we're so lucky to have treatments, but the treatments, they're not going to restore vision. And there's a burden to get an injection every month or two in patients who often have to rely on caregivers to bring them, so it's just the patients I think have to be very, very motivated for this to be, a therapy that continues on for them.
Jay, you kind of flagged a good question in the chat about how often we're getting autofluorescence on patients,
Hmm.
and I think that's a really great question. There's the longitudinal nature of what this paper is finding, obviously over time, but the frequency too. Like I typically was a 6Q 6 month GA patient monitor, but then the nature of some of these discussions for our high risk or like our index non-foveal involving GA patients, for some of them, when we're having these sort of parallel discussions we've been hinting at, those suddenly have become like a Q 3 or 4 month sooner follow-up, in part because there's other components that are outside of the eye that I'm seeing them with a greater frequency as we discuss therapy potentially. And so I'm actually ending up with autofluorescence a lot more frequently than I have typically just because some of these sooner follow-ups. I don't know what your practice patterns have been, Jay.
I mean, I think Q6 is reasonable. Like, and I think that's what a lot of people said when complement inhibition came out, whether you treat or not, is if you want to get OCTs more often for CMV monitoring, reasonable. Um, it's a slow moving disease. I mean, it can move faster, and we hear a lot of things about it does. It's not linear. It can be exponential in its growth, but still a slow moving disease. And I made the visual field analogy earlier, but anyone would call me on the issue with visual fields and why you may get them earlier is because there's a little bit of subjectivity there. So unless you're having image acquisition issues, your autofluorescence really shouldn't be changing that much day to day or month to month. I think Q 6 months, but I've heard some people say Q3 because they really want to follow them closely. And maybe, like I was saying earlier, an AI model could really get useful information out of Q3 that I just can't detect with the naked eye.
Well, I think on that, I think we've beat autofluorescence, perilesional autofluorescence to a proverbial pulp for a moment. I think we're gonna have touching back on the imaging and some of the other components of the study, which was size, directionality, location of it. I think is going to come back up in a little bit in one of our other papers on the atrophy advisor. But to let Matt finish his buckle, maybe Kat, if you want to take us away and talk about what we should talk about with our patients to for diet.
Totally. Yeah. So I included the other two PDFs I put in the chat. People haven't had to take a look at it. But this is an article in AJO that was published this year back in April. The title is What Should Patients with AMD Eat? Superstar list of authors. Senior author is Mark Johnson. Emily Chu is an author as well. And the first author is Tiernan Keenan. And so the purpose of this article was really for the authors to help summarize relevant data on what patients with AMD should eat and to help propose sort of more simple evidence-based dietary and micronutrient like supplementation guidelines that can be shared with patients. So what they did is they performed a focused lit review looking at this. And in general, the conclusions that they found were that sort of across different stages of disease for AMD, closer adherence to a Mediterranean diet was consistently associated with substantially slower progression of AMD. They also found in the ARED study that patients who had AMD who adhered more closely to this diet were significantly less likely to develop intermediate AMD. In AREDS and AREDS 2, they found that patients with intermediate AMD, that high adherence to this diet was also associated with decreased risk of progression to LET AMD, especially for patients with geographic atrophy. And then they looked a little bit at specific dietary components that were found to be influential. So they found that higher fish intake was protective, followed by higher vegetable and lower red meat intake. And for patients with geographic atrophy, they found markedly slower GA enlargement, including slower expansion to the fovea with adherence to this diet. And then in terms of that GA expansion, some of the key factors that they found were higher intake of fruit and vegetables, lower intake of red meat, and avoidance of heavy alcohol. There's been a lot of interest too on oral micronutrients, including the AREDS 2 formulation, which they described has been shown to slow progression to late AMD. And then they also found notably that the benefits of sort of a healthy diet and ARED supplementation were found to be complementary. So overall, in terms of the guidelines, sort of summarizing some of the data that's out there, suggests that people with AMD should follow this Mediterranean diet. And that the AREDS 2 formulation is recommended for people who have intermediate or advanced AMD, especially with extrafoveal GA, and that these things can be used together. I found this article overall, I think, really interesting because there's a lot of data and a lot of sort of interest in this. I don't know about you guys, but I have a lot of my patients will come in very motivated, asking about specific AREDS formulations, if there's anything else that they can do, or even buying other, nutrients, or they sort of read a recent article that some other nutrient or some other dietary factor was helpful. I think one of the things that the authors highlight, though, which is hard in practice, is, I think that we would all like to say that, advising a Mediterranean diet or doing that for ourselves is easy. But in practice, adherence to these things is pretty challenging. And that's one of the things that the authors discuss in the article. One of our fellows, Farah Santaki, who I love very much, I think has some interesting comments on this one. People think that Mediterranean diet is one thing, but other people think a Mediterranean diet is like eating pizza and pasta and having red wine. So the dietary stuff is interesting, but I think it was a really nice summary, and I'm glad that the authors put this together.
I think I'll pick up your last one first, which is, you just said I've always talked about Mediterranean diet. How much are we pressing our patients on the pop quiz? Can you tell me about exactly what you're doing to constitute the Mediterranean diet when you say yes to my, that, oh yeah, I'm doing that. I don't know, Jay, how in detail do you talk diet with your patient before this paper, maybe now after this paper? Are you going through explicitly, at least for me, when I read this, I'm like, okay, right, eat the vegetables, eat the fruit, right? There's specific component parts of it that I at least get to call out by name to them.
Do you want the proper answer or the real answer to this
I want
question?
everything,
Because
Jay. I want it all.
I mean, the proper answer is I spend 20 to 30 minutes talking about every part of their dietary components, mapping it out on paper, and then giving them an AI generated tool that kind of maps out what they should. The real answer is unless the patient initiates the conversation for AMD, besides mentioning, AREDS, we'll talk about AREDS, AREDS 2, AREDS 3, non-smoking, green leafy vegetables, colorful fruits and vegetables. It's not like I go and quiz them, as Kat said, about everything that they're eating. That's a little bit more challenging. And, I think this is a great paper, but again, I'm a question asker, questions come to mind. But one of the questions that came to my head is like for me, it was easy in the past if a patient had like intermediate AMD to be like, well, you don't have any better options. The data was there. It wasn't super strong, but it was there. Take AREDS 2. Like if it doesn't hurt you to tolerate, just take AREDS 2. But now it's like, well, the data's not super strong. There's PBM. People have questions about the data for PBM. Now there's AREDS 3. They added some B vitamins. They cut the zinc a little bit. There's not really data for that. I think I still probably would be like AREDS 2. But if someone was like, oh, should you take AREDS 2 or AREDS 3? I would be like, well, I don't know if it makes a big difference. We actually don't know from any trial. They're pretty similar on paper. So even AREDS versus AREDS 2, it was not an efficacy issue, right? It was just trying to add a little bit more, but none of the things that were added to AREDS 2 were ever shown to drastically change the outcome. So I liked what you said, Kat, and what the paper said at the end, which is kind of like, well, maybe it has nothing to do with any of the supplementation. Maybe it's just like you get in the healthy mindset. And so I'm like, yeah, this year, I'm going to take my multivitamins, I'm going to take my supplements, but then you also do other healthier habits that correlate with that. And that doesn't mean it's bad. It just raises the questions for the patients who are like, it's really hard for me to afford this, even if I buy it from Costco, or, I have a really hard time stomaching it, you know, and also raises questions for the patients who were not studied or proven in AREDS, who are asking you those same questions. The really advanced patients, or the patients who have a family history but no signs yet, who always ask these questions. Where you're like, I don't think it's going to hurt, but it probably won't help. So again, to go back to the psychological component, how difficult is it for this person? How motivated is this person to keep doing it? But it's sort of a fuzzy area, which is why it's interesting to talk about.
Well, I think anytime in medicine where we're talking about lifestyle modifications as opposed to like single things that we give or prescribe or recommend, it always that we become a primary care problem, right? Of the issues, that it's much more difficult to deal with that than it is to throw something at it and say, well, I'm taking something, I'm doing something for it, and feel good about that and feel like we're doing something. Dr. Starr has joined us. Thank you for preventing blinding disease, and welcome to the webinar.
Thanks. Sorry for being late. I'm surprised you're still talking. Is it the first article? Still the
No, we're on number 2. We're on the diet.
Oh, you're already number 2, diet.
Yeah.
And it's interesting. I mean, to comment on the diet aspect is, now I get these ACGME emails about I don't know if you guys have touched on it. They're going to incorporate a lot of nutritional guidelines, and that's interesting. I mean, there's a lot of pushback on some of that, but maybe some of this is legit.
I saw that. So, like, if for those of you who aren't aware, they want to incorporate there's an X percentage that's now mandated to include in residency education for ophthalmology, and that's ophthalmology. All rest, ophthalmology is relevant to us, and I don't remember that percentage. It's pretty high.
Yeah, it was a good percentage. I could tell you off the top of my head, but across all residencies, but including ophthalmology, nutritional education, nutritional guidance, and here I think. I mean, I guess I'm definitely biased, but I think it makes the most sense for retina to help modify and educate our residents on some nutritional guidelines, and we're teaching them how to kind of learn some of these things to help educate and empower our patients. I guess I should learn more about it and how this kind of affects other subspecialties, but within retina, I think it makes a lot of sense.
And the other thing too, I mean, I get those emails too, and it's kind of crazy to think about how you have to revisit, what like lecture schedules and other things look like. And I think that the other thing that the authors touch on for this article that's really challenging is like, we all have challenges with like time and seeing patients. It's like really hard to like have these conversations in like sort of a good and meaningful way. And, I don't want to make my patients feel bad, especially for conditions like, AMD or GA, where we're lucky to have treatment in the space, but we don't have, treatments that are going to like restore vision. And so, I don't want some little old lady like worrying at home that if she's not doing a good enough, if she has that steak, on Friday night for her birthday or her friend's birthday, that her AMD is going to get worse. I try not to make people feel bad. So I'm sure like we all do, we have little quips. People are like, is there anything else I can be doing? And I'm like, don't take up smoking. Well, try and eat some green leafy vegetables.
I mean, that's not a small point though. Like that, if you, I mean, certainly we have this experience with our diabetic patients. If you make them fear coming to see you or not like coming to see you, then they don't come to
Yeah.
see you. They're not going to come back. And then when something
It's
is
like
actually changing, then we've lost them, right? So like it
it's like
worse.
it's like cavity guilt, right? Like you don't want to go see the dentist to be yelled at that you're not brushing, or you're eating too much candy. If you're a kid or a teenager or an adult who likes candy, like me, it's just something that you don't enjoy. I, no one answered the spicy question, which is what do you do with AREDS 3? Because someone threw that out in the chat, and there's not really data. It's like a souped up AREDS 2. It's not really that different. I'm basically telling patients whichever is most cost effective for them. But I don't know if any of you feel strongly either way. Because I've heard of some people who are like, no, I won't recommend AREDS 3 because it's not validated in any study. I'm like, well, that's true. But it is kind of the only thing that changed that was different, that wasn't additive, was reducing, I think, the zinc, right? It was zinc or copper. One of them got cut. But the dosing was very not different. So I don't think it's okay. I don't think I would say don't use it. I'm just saying I don't see any evidence to use it instead.
Mhm. I Go ahead, man.
Yeah, that's what I say. I say there's trials enrolling and ongoing, and there's not, as you said, Jay, there's not data to support me advocating it for my patients right now. And we'll see. Juries to be determined.
It's hard because even before AREDS 3, there's all these different companies that will advertise to patients, like
Mhm.
some, slightly different version of AREDS 2 that's somehow better. And, patients will bring in these bottles and they'll say, is this one good? And I'm like, I don't know what this random formulation is and like what's in there. And so I just sort of say, I was like, look, the only thing that's been proven to be studied and, looked at in the studies is like AREDS 2. I was like, in general, as long as it says like AREDS 2, fine by me, and so it'll be helpful to have more information about AREDS 3. But if somebody's already bought it and invested the money, I'm just like, it's okay. But if someone's telling me this is expensive, this hurts my stomach, I try and make them feel better that they're doing, something, because who knows, what the difference is between these and how much of a difference they make to patients.
That's a big question I think I get a lot in my clinic nowadays is they come in with some sort of infomercial product and ask me what I think about it. It's hard. I mean, I guess it's not too hard. I just say there's no data to support it, but it's tough because I think this is a vulnerable population and
Yeah.
they want to try anything and everything. I guess outside of
Matt, where
lifestyle modification.
Matt, where are they seeing those commercials? Are they mostly still pulling from TV or newspaper, or is it more new school, like social media? Like, where are most people pulling this from?
My patient population is just pretty old, and these patients, as we know, are pretty old. I get a lot of them telling me it's from something they saw on TV, or their friends, or some sort of magazine article that's passed around the home. I get that one a lot.
Magazine friendly for sure.
Magazine, yeah.
Yeah, there's a lot of magazines like geared towards these patients. And I'm always struck by, especially in these patients, people do like outreaches to like assisted living facilities. I just had a patient tell me
Oh,
this
wow.
week that like they didn't know that there was a limit on the number of injections that they could get because this person, whoever it was, came out and said that whoever's like physician is doing an injection needs to like rotate around by clock hour of their eye.
Oh.
And then you're going to run out of space. And I'm just like, what? What is going
You
on?
guys, you guys don't change position every visit to go around the clock. I record it in the chart. 1 o'clock. Next time 2 o'clock. Next time 3 o'clock.
I do not by patient, but I do 12 clock hours, 12 months.
I mean,
in January we start at 12 o'clock and then we work around.
So I will say there are some people going to comment like there is something to be said. There are certain patients that if you keep injecting in the same site, you guys all know this, that eventually you do have to move, even if you're injecting small gauge. And that's much more common if you're doing an Ozurdex or something that's a bigger gauge injection. But even with 30 or 32 gauge needles, there's a small subset of our patients that, yes, eventually you do need to rotate somewhere else, whether it's for pain reasons or it's for the tissue just is starting to get thin in that area and you go somewhere else. It's interesting when you do vitrectomy in eyes that have had a lot of injections, you can look in the pars and you can sort of see that little pigment change in the area that kept getting injected. So there's a little bit of truth to it. I'm giving a little benefit of the doubt. Otherwise,
maybe your
my sarcasm was appropriate, I think, for that
65-year-old
comment.
monthly patients maybe need to be you need to be thinking about that site migration in the long term. But yeah, I wanted to ask one more question, going back to the AMD article, just because my wife brings this up every time we start talking about this. My wife is a China scholar and spends a lot of time in China, and so we talk about Mediterranean diet. And she always asks, is it really the Mediterranean diet or is it really like the non-Western diet, right? Like we have, and I don't know because I feel like it's what we have to study. That's like, that is the alternative that's often discussed. That's what was reviewed in the data.
You're saying just don't eat what we eat here.
Right.
That's
And so the authors have a paragraph that talk about this a little bit. That's
yeah.
like, we don't know that it's not, that there may be other sort of regions of the world with different diets, but it was a little bit of an aside. But what we have data for is Mediterranean diet, just because that's what we have from AREDS 2, and from a lot of the European studies. But I don't know how to answer the question. Obviously, Matt knows how to answer. It's a very complicated answer, but I don't have data to tell them about this other part. But it's a really valid point of, is it really the strict adherence to specifically the Mediterranean diet, or is it really just not eating what we eat? I don't have an answer, but I don't know.
Matt has an answer.
And when I was a fellow, an interesting article came out in the New England Journal of Medicine on intermittent fasting, and I jumped on the bandwagon because of that fellow. And I actually, as an aside, I stopped because it wasn't working for me. But it talks about a population in the Asia. It's like an isolated island population where they actually have lower incidence of diseases of aging, and they are a very strict intermittent fasting population, and they had lower rates of AMD. And it was just, comparing it to, really not a whole lot, but it was just an interesting kind of thought. And that kind of goes to your point. Maybe it is not just the Mediterranean diet, but there's something else about it. And I remember when I was a fellow, I was very eager, and I asked Emily Chu about it, and she said, "Well, we don't have really their diet, information in the AREDS, data set." And so I've never really explored it kind of further. But if there's other things on aging and other anti-aging, with metformin and other these new anti-telomere drugs and stuff. But maybe there is something with intermittent fasting and the way they're creating a state of ketogenesis to help kind of I don't know, anti-age their bodies, but at least they saw lower rates of AMD in that population.
So anti-aging, just to take it, biohacking is like the latest thing. Like people who are not yet sick want to biohack and become healthy. Cold plunges, different types of light therapy. I'm not a biohacker, so I'm running out of things to say. But like PBM is an area where there's a lot. In areas, and maybe not so much in Minnesota, but living in LA, I know that there's a lot of people in LA who are like the type who are getting like MRIs periodically on themselves, like anything for self-care, who are like, yeah, I'll get blue light therapy for my eyes, or not red light therapy for my eyes, and blue light blocking glasses. Like, I'm going to do all of this to prevent disease later. And my gut as a doctor and a scientist is like, that probably isn't going to do anything, right? Because you don't know your pre-treatment risk, but there's maybe going to be a subpopulation of people where it does do something, right? If you treat enough people with PBM who don't have any disease, you may get some people who it's beneficial to prevent a problem. It's just, we would never know who those people are. But I think that's interesting because that's going to be very geographic. Like we have Cleveland, New York, LA, and Minnesota represented. Rochester represented. I would assume on the coast this is more of an issue, but especially with social media and democratization of information, there's going to be a lot more people coming in to retina doctors being like, I want this as a prevention. I'm willing to pay cash for this. And that's an interesting question our field's going to have to answer ethically and scientifically, what we want to do with that.
That was an interesting segment. And I completely agree with the intermittent fasting and the whole wellness thing. And sometimes it gets to this weird, social media, kind of like what you're talking about. I am fortunate that I do not get a lot of those questions, and I don't have to field them.
We get a fair share in New York.
I was gonna say, Kyle was so quiet. He's just like waiting. He's like,
it's a little bit dramatic for me to bring up and talk about. It's just that there's a long, deep. That's pretty much what we just heard is how I react when that question comes up.
I think Matt and I are pretty aligned in our patient population.
Yeah,
I'm more sympathetic. I'm like, it's okay. It's mostly like genetics. You're doing the best you can.
Yeah.
And but some people are okay with that. But again, if you get to certain areas, there are people who are less okay with that answer, who will come with something. Just like it's the equivalent of your infomercials, Matt. It's just a different sort of thing.
Yeah.
I think that the difference is that and the coast, there's a variety of practices and a variety of options and a variety of different places to go to. And whatever my answer is going to be, there is going to be somebody who they can find who will give them what they want and give them the answer that they want, and they will find it. Right. And I think that's one of the big, perhaps the bigger differences, and it may not be me, but there is a saturation of positions in healthcare that caters to that kind of drive and demand. So I think that people will find, if people want it, they will find a place for it. Just might not be in my office. I think Jay, unless you had something else to say to that.
No, I laughed at you. I mean, this is a great subject, but I want to hear Matt talk about this next one. I'm
Let's
excited.
do it. Let's talk about Atrophy Advisor, our risk calculator. I love this because somehow we talked about really, lesions, and then we talked diet and death, which are really common, like, retina practice. So Matt, tell us a little about the
Yeah,
Atrophy.
so we're going out a little out of order for me, and I appreciate that. And so this was a paper out of AJO, good source, good authors, and essentially they made they called it the Atrophy Advisor. You actually have a website. I don't know if you guys went to it and checked it out. It's functional. You can enter your own patient information, and then they'll kind of hit you with what the growth rate and predicted foveal time is. And so it is, as the title says, that they developed a clinical tool for dry macular degeneration progression with geographic atrophy. And as we all know, really the study was motivated by your current treatments, and the questions we have for geographic atrophy patients is, they don't really help vision, but they, perhaps slow down. Yeah, and they've got a lot of risks. You got to, do frequent injections. They're expensive. And so, is there a better tool, can we get to predict progression to the foveal center, time to foveal center, and then what they kind of did then is a novel aspect is they developed this algorithm, but they utilized the potential patient life expectancy, which really is kind of a unique twist to their study. And so they developed this algorithm. They described in detail kind of how they do it, and they analyzed 50 retrospective patients with atrophy at Wake Forest, utilizing serial fundus images. And so they took, what's novel about it is the perifoveal, so not involving the fovea, closest to the fovea lesion, and the distance from the fovea to that lesion, and then they measured that over time, and then they took the growth rate of, the growth rate of that distance, and not really the lesion size. That's they didn't incorporate that, which a lot of the trials do, and they talked about that extensively, how that's different. And so they took that essentially distance over time, and they compared that to their calculator, and then they also imputed patient life expectancy through a couple of different parameters too, and then they just kind of compared the results. And so what they found at the time, the baseline distance from the fovea to these lesions was about 800 microns at the start of their study, and that it decreased to the final follow-up to about 395 microns, encroaching towards the fovea. And just looking at all comers, the progression rate was about 122 microns per year. It actually kind of varied. We can talk more about this. Some only progressed 2 microns a year, and some progressed 626 microns a year. And one thing that they note, throughout, is that the further away the lesion is from the fovea, there was a significantly faster progression rate. And essentially at during the follow-up, 16% of patients did actually develop foveal involvement with a median time of 2.1 years from non-foveal to foveal involvement. Like I said, the lifespan calculators that they included were pretty similar, differing by about 1.2 years on average, and only changed the treatment recommendations for 4% of patients. And that they based the treatment recommendations on if they were expected to experience foveal involvement within their lifetime. And this advisor, this calculator, within this population predicted that about 74% of patients, who live long enough will experience foveal involvement. And so it's an interesting proof of concept tool. It combines disease progression with patient life expectancy, which is unique to potentially personalized treatment decisions. It's limited. It's a small sample size, retrospective design. Manual image analysis and algorithms, which are be fraught with some reproducibility issues. And then the big thing is they don't include, and they talk about this quite a bit, is they don't include systemic or ocular risk factors, into that. So they're not including, pseudodrism, they're not including other eye involvement, they're not including any genetics. And they talk about how this is again a proof of concept, potentially a starting point that we can help launch some of this. I guess I kind of lost. I didn't talk about it too, but they didn't include GA lesion type, whether it was a multifocal or focal lesion. They talk about how multifocal lesions progress a little bit quicker than focal lesions, but they don't include the type in their analysis. But it is interesting. It's proof of concept. I checked it. I plugged in some information. They talk about how they validate it compared to a lot of historical, really good historical studies, and they're very similar growth rates, progression rates. And so that this is potentially a useful marker, to identify patients at their time point they may involve the center, and then also what if they ever may even actually have foveal involvement.
Yeah, thanks, Matt. It's a really, I love this proof of concept you say, and the authors are very quick to say this is not a be-all calculator, but just I think for retina specialists, it's a pretty novel discussion to be sitting there talking or thinking very actively about life expectancy, and frankly, in a way that like we probably haven't really thought about in ways since medical school or intern year, in a formalized sense, right? But it's the question every time I see a non-fovea involving GA patient is the fovea going to outlive this patient or not, right? Or are they going to outlive their fovea being involved? Jay, you showed us a case in Austin when we were discussing the first question, how old is this patient, right? Mm-hmm. It's always the framework. I don't know, Jay, when you see this, what are you looking to add to the calculator? Because it's a pretty simple metric, but what else are you trying to incorporate in to try to get a better sense or more representative?
I mean, Matt pointed out some of the low hanging fruit that they could add in the future, right? More ocular risk factors, fellow eye history. But I think the one big limitation of this, it's interesting that they had to use Social Security data for lifespan, but the lifespan is a dynamic metric, right? We just spent all this time talking about biohacking, all the things people are doing to live longer. We've sort of joked like, oh, you're going to live to 100, 120, 110. But I mean, if you look at it, like 1900 was 125 years ago. The average life expectancy was 30. Today, the average life expectancy is 73. I looked this up and took notes. I didn't memorize this, but the point is that like that's global. That's not even the US or developed countries. So like there's obvious medical advances that have made that possible, but as people live longer, the calculator has to adjust for that. And so the calculator is always going to be a little bit behind in terms of lifespan, unless there is something that drastically reduces lifespan in the future on the horizon, whether it's a pandemic or a natural disaster or a war. But if that doesn't happen, then I wonder if you'd have to bake in some sort of correction factor, which is this is your average lifespan, but now we've also calculated in the slope of how average lifespan increases over time. So yes, your number would have been 11, but it's actually 14 or 15. And you may not think that matters, but if you're starting to make treatment decisions, or I'm thinking badly or cynically, what if it's an insurance company making insurance decisions? Yeah. Then you want it to be on the patient's side because you actually don't know how long this person's going to live for, but it's probably longer than you think. What we expected when we were in training, and I finished medical school 16 years ago, life expectancy has increased since then. So I can't keep that same mental quote unquote age bias in my head in 10 or 15 years from now if it continues sloping up like that.
Yeah, one thing it doesn't do is, I mean, it also doesn't tell you, who's going to potentially respond, to some of the potential treatments. I think that's what we talk about. Maybe they'll, reach foveal involvement, but if we intervene, did it actually make a difference in this population? And that, again, that's still kind of what I'm looking for in some of these, treatments is, okay, sure, this is something I want, I need, who's going to get involved, but also like maybe they're still going to progress no matter what I do. And I think that would have been kind of helpful to have. But I mean, that's a great point, Jay, is, things are going to change. Life expectancy is hard to predict. And this is, it's a start, but yeah, they've got to somehow figure out how to, adapt.
I do. Sorry,
Okay.
Kat. I just do really appreciate how this calculator, I mean, we talked about earlier about how I think we're all a little bit more paternalistic with the area of GA than some of our other treatments. We try and sort of read the room if we think someone's like a good candidate and if they're interested or not. So I like how metrics like this are trying to sort of capture that information a little bit better. It actually like raised something to me is, you know, like I often don't do a great job before I'm like seeing a patient for the first time and just like looking through if they have any other clinical non-ophthalmology notes in the system to get a sense of who they are. Like I really have that benefit in our system and that almost everyone's care is like done in our system. But to be frank, I don't. And sometimes patients will be like, well, you saw my health has changed since last time. And it's hard. Like we see a lot of people. I don't always do that, you know? So I like how this captures that, it captures at least a little bit more data in that way. But you know, maybe tries to objectify the things that we're sort of trying to make snap judgments on when we go into a room of how to frame the GA conversation.
Do you, I'll ask all of you. I mean, we're sitting here talking about life expectancy and mortality. Do you tell your patients that when you're bringing this discussion up?
I didn't used to make conversation like I used to like not make promises at all for patients. But I think over the past few years, like some of my patients with AMD, when I get the vibe that they're feeling very anxious about things, and I feel like they have AMD, but they don't have significant, you know, burden of disease like Drusenberg or whatever, I've started making some like comments like, I don't think this is going to be a disease that's going to cause you to like go blind over the course of your lifetime, you know, versus I think earlier in my career, I used to be like, I don't have a crystal ball or whatever. But now I just find that it's so reassuring to as we've talked about, this very vulnerable patient population. And, you know, if I'm wrong, I don't think those people are going to be like, you know, totally pissed at me. But I find that actually means a lot to patients. I think when you make some observations like that, even if I don't know what their life expectancy truly is.
We're talking about GA, but I think also something to file away if you're a student or resident or fellow listening is like, if someone's gotten to 95 and they have just a few drusen and no GA, they're probably not an aggressive disease because they're not in that subcategory of people who progressed younger than that, right? So like, and I think that's where like not all drusen equals dry AMD. Like they used to say any drus with dry AMD, then life expectancy increased and they got more photos and OCTs and people were older. And like, well, actually it just happens sometimes. And that doesn't mean it's AMD. And the reason they made that distinction is because some of those patients don't progress. It's just there, it's asymptomatic, doesn't affect their vision. So that's part of it too. I was smiling a little bit because I could hear a lot of poor ways of phrasing that question in my head. Like you see all the possibilities like Neo and the Matrix, and they're like, there's 14 ways to say this that are wrong, but this is the correct way. But I find that patients and our family, especially the patients, often are the other way where they're like, well, there's no purpose in doing anything because I don't have that much left. And that can be in situations where I'm like, no, we actually should do something. You're still functionally doing this and this. We should treat your wet AMD and or we should fix your RD and or yeah, you should get cataract surgery. I don't find that patients are arguing with me the other way, being like, no, doctor, I need treatment. You don't think I'm going to live long enough. So I think it's flipped sometimes.
We talked about fillers before, right? And like introducing, and I'm like, in a morbid way, how they bite on that question is a fair feeler. At least stuff like this atrophy, it gives some number, right? That like helps the discussion, not a general like, I don't have that much time left. Or they may mean a decade. They may mean, you know, I don't know what they mean by some time left, right? And I think there is some quantification that like helps that discussion a little bit when we start taking feelers. Because you're right, Jay. Like I have a lot of those patients that are just, well, I don't want to do that. I don't want to spend any time in the office. I don't have that much time left. And they mean 10 or 15 years still, not, you know, a year or two.
This paper may give a little bit of help to some of those questions because, you know, people make this analogous to like glaucoma, you know, it's something we're trying to prevent. It's a silent, you know, vision threatening condition. Well, I think most of us would never not treat glaucoma despite someone's age. At least I think. I guess I don't know what a glaucoma surgeon does if they're 95 with a mildly cut disc, but I think for us, if we had a predictive, you know, tool that they were, you know, a fast progressor, you know, if they're 90, and we knew they would respond. I guess I could see still a reasoning for treatment. I get the question, as you said all the time, is why are we doing this? And I said, I'll treat your vision as long as you've got, because it's worth having good vision for the rest of your life.
I'll ask one question just because they chose an interesting metric, which was just a single metric of distance. But I think we've talked a lot about, and Matt, you went into the weeds a little bit about rates. They provided linear growth rates, right? But is that linear growth rate really a valid estimate? And there's a lot of differences in growth rates depending on proximity. I don't know what your thoughts are about using that linear assumption in the calculator for what I think we all know is a nonlinear metric, right?
Yeah, I mean, they kind of did the point about it in the discussion. I think there's a lot of math and science that's a little bit over my head and some of how they use a calculator. But in using that metric, they discuss how it's pretty similar to other previous studies, how it's very different still than what's been published in the clinical trials. But they feel, and I think I would agree with them based on some of those marks. It's what we kind of want to know. I think we want to know when it's going to affect the fovea. If the lesion grows extrafoveally, I'm not too concerned with that. I want to know when my patient's going to lose their vision.
The spicy question I put in the chat that no one's chosen to address: is there a maximum age for any of you where you're like, I'm not going to do any complement inhibition? Is there a number, or is it no? Because someone asked me recently about like a 95-year-old, and there was a part of me that was like no, and I was like, well, yeah, I mean, if they're functioning, right? But like, I wonder, is there an age at which you're like, I don't care how functional they are, it doesn't make sense? What are your thoughts on that?
My 90s was starting to come to mind with that, but I think so much of it is, the first is not the number on the computer screen we see when we go to see the patient, but like when you walk in and see what they look like sitting there. It's a simple assessment, but did they walk in by themselves? And if they walked in by themselves and they're independent, then that's not somebody who is 95 and that we're talking years. It's still a life expectancy calculator question, just where the base number of age is really not the relevant metric. So yeah, I think I had the same reaction. I would have said 90s, but then I can think of patients in their 90s of mine who are definitely candidates.
Yeah, Ross just put in the chat, 104 lady who wants treatment is very functional. Who are you? I mean, that lady could live another 5 to 10 years. There are people who are living that long.
I have so many patients that are 105 and their single problem is macular degeneration. It's I'd never saw that in Philly, but in Rochester, I've got an interesting patient population, and then
what are they eating?
I know what are something in the water, man.
It's not the Mediterranean diet, Kyle. It's just don't eat this country's food diet.
Yeah.
Everything else is okay.
No, I feel like genetics is like
potato hot dish.
I feel like this, like genetics is
Yeah.
so much of this. Like my grandmother lived to be 102. Peter Kaiser saw her for like wet AMD, and she had the worst diet ever. She probably existed on like coffee that was basically
now you're
like
just humble
sugar
bragging.
and
It's like,
butter.
yeah, it's like,
No. I always joke that I'm gonna, but I know, you know how
you're going to be doing
is.
hologram VBS webinars in like 70 years, and you'll be looking great. I think genetics is a huge part of it, and yeah, I don't think there's a maximum number for me anymore. Even for surgery, this is a whole separate stuff. Maybe there isn't a maximum as long as they're healthy enough, right? To get anesthesia or sit for surgery. But anyway, interesting question. Great article.
Yeah, I really love it. I'll go back to where we started with the autofluorescence of saying, is this something where we just have the AI calculator ultimately that it can incorporate a lot of the other variables that we talked about, right? I think one of the things with this is just wanting so many more components to a very complex, nuanced calculus. And this is a really great choice of a couple select ones for proof of concept, but I'm sure there will be a way of going about doing it to incorporate a lot more variables.
Yeah, we just can't fall into the science fiction movie trap of also telling the AI to solve humanity's problems, because then it will be like, don't treat anyone. Humanity will do much better if they all go blind and die and the world is just peaceful, But yeah, just, all seriousness aside, I do think an AI calculator will make a lot of sense. And ideally, to your point, Kyle, combining both into just one giant calculator where it just reads the imaging, takes your patient information, pulls it all in, and gives you something to tell you what to do.
And isn't that kind of like the point? I kind of was alluding to this earlier, like as retina specialists, how good are we interpreting a lot of that other clinical information in terms of life expectancy and into the calculator? Really, our minds have now at this point spent a decade plus of really thinking retina with some awareness of systemic diseases that will complicate anesthesia for surgery. but you know, it's hard for us to put it all together without that. So anyway, it's a good future role. Well, I think in the interest of time and make sure that everybody can get on to watch more important things this evening. I want to thank Kat, Jay, Matt. As always, it's a pleasure to spend time with you and talk retina. One of my favorite hours every couple of months. Looking ahead, there's going to be an upcoming new inaugural VBS Fellow Research Day on September 29th at 8 p.m. So please, everybody who's here, be on the lookout for some email blasts regarding submissions. And I want to thank Astellas again for their support of this webinar and for the content. Really, thank you. It would not be possible without them. Thank you, guys.
Good night.
Yeah, thank you guys.
Recording stopped. you.